Okay, so good afternoon from New Delhi, India, and I am Dr. Praveen Chandra, working at Medanta, the Medicity Hospital here, and along with me is my colleague Dr. Nagen Chauhan and Dr. Ankur. So Dr. Nagen Chauhan, he is a senior interventional cardiologist, and he is going to explain to you about this case and the plan because this is going, I mean, we want this to be as interesting as possible for everybody, and we will try to give you as much educational value from this case as possible. So and before he starts, let me also, just introduce the team here, which is looking after the imaging, the cath lab, and all the people, the nursing staff. They are all well versed in doing imaging procedures in complex coronary interventions, and we have everything ready. Dr. Nagendra.
So good afternoon, friends. This is an interesting case. He is a 69-year-old male. He's non-diabetic, normotensive. He presented with exertional angina class C, and for which an angiogram is done, which showed a critical disease in the RCA and a critical bifurcation in an LAD. You can see here. Can you show us the first shot? So initially RCA was stented. The circumflex was stented, and the circumflex and DB was done. So the plan was basically for now to do a bifurcation angioplasty for LAD, but the diagonal is also a significant size vessel, and LAD is also a seems like quite tortuous vessel. So the plan is that we should dilate both the lesions with a cutting balloon to cause minimal intimal injury, and then see for the IVUS and the main vessel if how much is the calcium. If calcium is significant, then we will discuss about the calcified lesion angioplasty in detail during the discussion, and then we'll decide for the plan what is the best plan for it. Should we go for bifurcation angioplasty with 2 stents, or should we go for provisional, or should we go for some new kind of thing, a newer innovation that we will try to avoid too much of matter in coronaries. So all these options are open till now, and as per the imaging guidance and FFR and IVUS guidance, we'll decide on this. So there is a FFR bar in the LAD and a normal bar in the diagonal. Now we are going for imaging of the LAD, and on the basis of imaging, we will decide. So initial baseline IFR for LAD is 0.81. We'll just show you. So which showed a significant in LAD, although it looks like quite significant, so there is no confusion. Diagonal is also quite significant, but quite tortuous lesion. This is the IFR value of the LAD. And as you can see, diagonal is quite tight. So now we are going for an IVUS imaging for LAD that will decide the future plan.
Okay, so this is my IVUS catheter in the LAD, and switch on the IVUS, please. So as Dr. Nagendra was discussing, that in this bifurcation lesion we can do it in so many ways, and there are a few things which are very interesting, that the main vessel is at least looking like a 4, and then there is a sudden tapering leading to this vessel going to be like a 3 millimeter vessel, the LAD beyond the bifurcation, and this diagonal is also looking like a 2.5 vessel. After that diagonal, again there is some disease, so it's a diffuse disease, but certainly there is one point which is very tight. So we put the wires in both the vessels, the diagonal. Now we can, so let me just do the imaging. So show the imaging, please. So I'm pulling back. You can just take a shot and see where we are. Take a shot just to show. Okay, yeah. Okay, so we can see that this part of the vessel is quite healthy. Now there is some calcific plaque on the 12 o'clock position, and this is the branch.
The septal branch.
Septal branch.
Quite big.
And so here we see a calcified lesion, and here it is a 360-degree calcium. You see, quite dense calcification, just as a ring. And then the LAD is looking quite nice.
Quite nice, 4 mm.
So this is very interesting. And if we put a stent, then we have to, there are 2-3 things which can happen. One, that we take a stent, and then the stent has to be taken. It cannot be more than 3 millimeter stent, because the distal vessel is 3, and then we have to go up to 4, or maybe a 4.5. What is the proximal LAD size? Here it is about 4 millimeters. So this will be a tapered conical stent, which may not, be a great idea. The second is that this diagonal can also get affected. Then we have to put a second stent. So which means we are saying that, if we go this way with a stent in the main vessel to LAD, then we will have to, be ready with a second stent
The
also.
second stent.
So that is why we thought that in case if we are able to shock it, so the plan is now to shock wave the
LAD.
ring lesion of the LAD, see how much we can expand, and if we get a good result with the the shockwave balloon and maybe a cutting balloon here if required, and then reassess with IVUS, and we already have the FFR wire inside, and we'll see the IFR. If the IFR is normalized, then we don't need to put a stent over here, and we'll do a drug-eluting balloon. So let me see now. We are getting the shockwave ready. In the meantime, what we can also do is we can dilate this diagonal.
Diagonal.
So give me the balloon 2.5.
2.5 cutting balloon.
2.5.
So we can debate
15.
this, that if we do a double vessel stenting or bifurcation stenting versus we leave just on
So this is
dilatation.
a new different way of thinking, that in these kind of lesions, if we are able to, especially with this kind of a discrete lesion, very discrete,
2.5 times
15.
15.
So we are going to dilate this diagonal first, and then go with the LAD. Have this.
So, Dr. Vince, have you seen so many patients you have done now? Have you seen any patient coming back with thrombosis or restenosis after leaving them without a stent?
Oh yeah,
What
that's
is
a good question. If when we do these kind of complex stentings, certainly the chance of having a stent thrombosis is higher than normal situations. One, that it is a tapered stent. Two, that we are it will be most likely if it is a two stent technique. Again, we have seen in most of the studies that one stent is better than two stents.
Yeah.
So now we are trying to say that maybe no stent
That
is better than one
better
stent.
than one stent.
So that is why we are trying to treat this vessel as best as possible, do a good angioplasty. So we'll try to do a good angioplasty and see how things work. Which part is this? This is the
This is the
diagonal.
So
Okay.
that's why the FFR wire is kept in LED to see once we have dilated and done everything. If flow is good and FFR value is okay, it means chances of thrombus formation are very less, and we can safely leave them without putting a stent. The lesion is quite tight. I think we may have to dilate with the 2 mm balloon. The cutting balloon is taking some stress in crossing. Yeah.
Some resistance here, but it has crossed.
It has crossed the first lesion. I think the second lesion is still there.
Okay, fine. Yeah.
Yeah, now it's crossed.
So we have crossed this, these two lesions, and go up, please. 1, 2, 3, 4, 5.
So very tight calcified lighter lesion.
Calcified lesion. 6.
So it's a balloon crossable lesion, but balloon is not dilating.
Now it is gradually giving way. Okay, deflate.
So what are the other ways to deal with these kind of situations? Like a balloon is not dilating, we use cutting balloon, or Dr. Chandra can give some light on this. We can use either very high pressure balloon, we can use rotablation, but
7.
the vessel is not very big.
So you can see that this is quite a tough lesion in this diagonal also, and that is why we thought that in this situation using a Wolverine will be a better idea. Okay, so 6, 7, 8, 9, 10.
So still there is some band which say that vessel has not given way.
I think now it has given way.
Now it is going, yeah.
Well dilated. Yeah.
Yeah, finally there is some good lumen. I think for diagonal this much is sufficient. We don't have to.
This is quite good actually. Okay. Okay, deflate.
The only other way is we can do a shock wave in diagonal also. But I think.
But
This is a good.
I think, doing that, it will be
Too
too
much,
shock
too
waves.
much,
So because here we can only take a 3 millimeter.
Yeah.
So, okay. So this is dilated already now, and okay, check it. That looks, there is some dissection definitely in the
But I think
diagonal.
flow is,
Yeah,
there are
but the flow
multiple
is
branches
okay.
actually. There are 2 branches there.
Yeah,
So
yeah,
they're overlapping. It
they
looks
are
like dissection.
overlapping.
But
So
yeah.
we'll keep the wire there and then see what happens to the LED now. Okay, so we'll take the shock wave, 3 millimeter shock wave. So we'll go directly with the shock wave. However, sometimes if the lesion is very tight, then we have
May
to
not go.
pre-dilate.
Yeah.
Sometimes even do a rotablation first. But in this case, I think, there is no need to do a rotablation. There is no need to do anything else. We will just do that shock wave straight away. So he is now connecting the shock wave.
Shockwave
and
solution. To connect the shockwave, we have to make sure that there's no air inside. So we have to give a lot of time to make it sure that there is no air inside.
And this is the same wire, which is the FFR wire we are using. This is the Volcano FFR, and we will reconnect it after we have done the dilatations. So sometimes people may also say that, why not try a cutting balloon? But the point here is that since we are seeing such a severe degree of 360 degree of calcium, why not go upfront with the technology which is more proven for calcific rings? So it's a calcific ring which we are going to treat now. And moreover, one very interesting thing, that this patient is also having some kind of very intense aversion to getting a stent done. So that's why we are maybe he had some, in family he had some patient who had an issue with the after the stent. So he is very mentally very averse to getting a stent implanted. He is happy with everything else except the stent. So he may be right to some extent, but we told him that it will be we will see. We will try to avoid as much as possible, but certainly still try to keep it as safe as possible. So here is the 3 into
12.
3 into 12. 3 into 12. Okay. Come bring it far ahead. Okay.
Yeah, very
Okay.
easily crossed. So
Okay, it is.
possibility is really good for this balloon.
This is the new one, right?
Yeah.
Okay. This is fine.
Yeah.
Okay.
Go up. 4.
Yeah. Yeah.
Yeah.
So you can see now we are giving the first set of pulses, and
there
the
is some
balloon
dog
is
burning that
expanding
is
very
part.
well,
Yeah.
actually. Yeah, balloon expanding very well. Deflate. Check, please. Maybe we have to move a little bit. Right? Yeah, slowly it has come back a little bit. Okay.
Go up again.
Check more once. Slightly more ahead.
Yeah. Go up 1, 2, 3, 4.
Yeah.
Again, you can see multiple points of lesions, and we'll go with this. So next set of pulses.
67, 66, 65. Okay.
So there is still some dog burning at the
Yeah,
bifurcation.
still some there. Okay, deflate.
So we have to give
Okay,
some
we'll
time
give
to
him some
breathe,
time
and then,
to,
yeah. Circulation of LED is
So in this
important.
situation, I think it is better to give all the pulses.
Better
Because
to
there's so much, because
make them. Yeah.
what is the harm? There is no harm in giving all the pulses. In fact, it would be better.
Yeah, more breakage of calcium and less intimal injury, so
Yeah.
chances of
Well,
that is also good.
1, 2, 3, 4. Yeah. Okay.
So this is the concept to be tested, that if we are just doing this, possibly we are giving less intimal injury, less medial injury, and breaking the calcium better for standardization. So I think more studies are required to prove it, but possibly this may be one of the good aspect of this technology.
Deflate.
We are inflating at a very low pressure.
So we have given 30 pulses.
Yeah.
Okay.
Okay. Again, go up.
Go up.
1, 2, 3, 4. There is
Okay.
still one point where the calcium is still visible.
It will give all of
Yeah.
them. If you can even move the balloon, because I must tell you one thing, that these emitters are actually emitting in one dimension only. So there may be a some
Different
area
dimension.
at 90 degrees of those emitters that will get not that much of energy. So if you move it a little bit, if it is possible, it might help. Okay, deflate.
We can do.
So I am going to move it a little bit. Yeah, yeah, it's looking good. Okay, I will try to.
Rotate it. Yeah.
That's fine. That's fine. Okay,
Go up again.
go up. Yeah.
Starting pulses 39, 38, 37, 36, 35, 34, 33, 32, 31, 30. Stop. Deflate.
Deflate. So, okay. Okay, go up. 1, 2, 3, 4. So this definitely takes more time, but we are doing it like a stentless angioplasty.
Starting pulses 29, 28, 27, 26, 25, 24, 23, 22, 21, 20. Stop. So definitely it takes too much time, but I think giving less injury and making a good space and preparing the vessel well will definitely will have better result in long term. So what we want to achieve is a good human, so that there is no risk of stent thrombosis of the vessel, as we are possibly trying to put no stents.
So sometimes people are scared of some when they see such kind of small dissections here and there. So, but we have seen that even if you leave a type B dissection sometimes or many times, they will never thrombose if the lumen is good, if this is non-occlusive. Okay, go up, please.
Nineteen, 18, 17, 16, 15, 14, 13, 12, 11. Stop.
Deflate.
So that's why this time we have kept an FFR bar in the LED, although some people may not keep it. So if the flow is good, you can still leave it. But FFR will give us an endpoint that if FFR value is good, you still know that 100% sure the flow is good and chance of thrombosis are very less. So this is one of the ways to objectivize this procedure. But some people are doing it without this also, and with experience they say there's no need of
4.
FFR.
Go up 4. So this is the last couple of
9,
pulses.
8, 7, 6, 5, 4, 3, 2, 1, 0.
Okay.
Deflate.
So we are done. And now all the pulses are finished. I'm trying to take it out. How much heparin we have given?
10,000 we have
10,000.
given already, and
So normally
ICT
we
is
give
300. Yeah.
10,000, especially in a little complex procedure like this, because it take some time. So now at this stage, we can check the IFR. Check the IFR, please. Let's check the IFR.
No, the same patient.
Same.
Open the same patient. Don't go to for a new patient. IFR पहले किया था ना? उसी को खोलना पड़ेगा. नहीं तो फिर से 0 करना पड़ेगा. Okay.
हाँ. Retrieve. Okay. Now live कर दो उसको. FFR.
नहीं IFR करो.
IFR. Okay.
Yeah. Live. No, then so you have to do zero again.
So what we should do is, we should check how much the IFR, if we can check it. Otherwise, I will do an IVUS to figure out what's the lumen. Now we have it. Yeah. So now the IFR is absolutely normalized.
Can you?
Yeah. PDPA is 1.01. Excellent. Yeah. So the PDPA is 1.01, 1.02. So we are good. I think it's absolutely fine. Yeah. It is.
Yeah.
Okay. Fine. So I think physiologically we are doing well.
Yeah. Take it.
Okay. Okay. Good. So
You can take a shot.
let's check a check shot and see. Yeah. So we can do one more dilatation with a balloon. Give me a balloon, please. 3 millimeter balloon. 3 millimeter. Yes.
Cutting balloon. There is no visible dissection and the vessel is open, but at one point it looks there is some lesion, but IFR wise normal.
Give me a 3
So flow is
balloon.
good.
Wolverine. ET. 315 should be good enough. 315. Yeah. So both the arteries are doing well. There is no compromise in flow anywhere. We can give some nitro, please. Shall we give some nitro? Yeah. Virus. I'm going to keep it back. Diagonal. Okay. Yeah. So the IFR was quite good actually. Baseline was 0.9 and it became the 1. So now I'm taking a, this is a Wolverine 3.
Yeah.
3 millimeter. Deflate please. Okay. So this is a 3 into
10.
10.
Yeah.
3 into 10. Okay. Yeah, it goes very easily. Not a problem.
In diagonal, it took too much time to dilate. Now we'll see how he behaves in this LED after this IVL treatment. So the calcium in LED was much more than diagonal.
Okay, check please. Yeah, that's fine. Okay, go up.
1, 2, slowly go up. 3, 4. Dilation is actually good. Without any high pressure, that's dilating very well.
9, 10.
I think IVL has done its job.
12. Deflate.
For the reason.
Check please. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I think it's quite nice.
Yeah.
Deflate.
Take a shoot.
Check please. Yeah, we are fine.
Right.
Go up. 1, 2, 3. Because beyond the septal there was nothing. Okay. 10. 12. Okay. Deflate. So we have done it with a 53 into 10. Now we will see how it looks.
First we should do IVUS and then decide on DB.
Yeah.
IVUS.
But the good thing is that the physiology is restored completely. And And also you see that on the circumflex, show the first shot, please. Show the first shot. The circumflex was treated, it was a total occlusion. It was a long lesion from the first OM till the, the third one. And this was treated with just a cutting
DEB,
balloon and
cutting
drug
balloon
eluting
DEB.
balloon.
And the result is
And
quite good.
vision good, looks good. And there is no recoil, nothing.
Flow is TME3, so chances of a thrombus formation now are very less.
Okay. Okay. So here we are. So IVUS, please. IVUS, show the IVUS.
So this was distal to the lesion. Now coming back, there is a calcified plaque here. There is some
I think it's okay.
fibrous tissue, but otherwise, yeah, vessel lumen is
lumen
quite
is
good.
good.
There is nowhere a tight lesion, and this is the main
So
vessel.
this
You
is
can see the cracks. You
completely,
can see the cracks,
ring is
multiple
completely
cracks. Yeah.
broken. You see, and it is expanded.
Multiple cracks are
Wow,
visible.
that's excellent. So this is, the ring has been broken,
Yeah.
and the, sorry, where's the wire? Is the wire out?
No.
Okay, so we are really in a very good position, and we are ready now for the drug balloon. Okay.
Yeah.
So what size drug balloon you are giving now? For
Three,
the
three size and longer
three,
size.
three.
350
For the LED.
to 15 or 20, 320.
So we are today
320,
going
25.
to use this is a 320 and what 320 will be better, I think.
320.
320. So this is a solution from Med Alliance, solution SLR. So this is a new sirolimus eluting balloon, which we have actually tested first in man, also in the solution 1 study, which was done here, and we showed that the the TLR rate, the MACE rates were extremely low. There was no incidence of acute occlusion. And now there is a big study going on right now across Europe and from here in India as well. And this is the solution in multi-vessel de novo disease. So this is a de novo disease which we are going to treat now. And you can see this is a different technology.
Yeah.
There is a difference in this technology and the technology which is, because they're the paclitaxel electric balloons, sometimes they are with the contrast, they are loaded on the balloon. Then we have the other balloons which are with some polymer.
Yeah.
And this is in small, these are small spheres in which the drug is loaded on the balloon.
So the release will be much more delayed than normal.
And they have seen that the drug stays there till 90 days.
Which is what is there with the stents also.
Yeah.
So we are getting all the benefits of stent without a stent.
So up to 90 days it has been detected, and the concentrations are reasonably good even up to 30 days, and going up to 90 days the drug is has been detected. Okay. So I'm taking this balloon here. So this is one of the best, I must say, at this time, technology wise, balloons, which is the solution balloon. Okay. So I think we are in good position. You can check. Yeah. Okay.
Go one, two, to go
Shall
more
we go a
forward.
little bit more?
Yeah, more.
We can go. Why not? Check, please. Yeah, that's fine.
This
That's
is
fine.
good.
Good. Okay. 1, 2, 3, 4. At 4, 5. So the nominal is 6. So we can go up to 6.
Yeah.
Yeah, 6. And we will keep it dilated for about what? 30 seconds?
At least.
No, maybe even 1.5 minutes or 2 minutes, as long as he can tolerate.
Yeah.
So in the study, the minimum is 30 seconds. But we generally, what we do is we keep it for about 2 minutes.
At least 1 minute, yeah.
It works. Okay. So there is no residual. despite that heavy calcium and everything. And you saw on the IVUS that the ring was so nicely broken and the whole thing got expanded. Show the IVUS, please. Yeah. Go up a little bit. Yeah. That's right. Oh, this is.
So for cases like this with calcium, which is not very
it is fully
superficial, this
now.
is good. Yeah.
Well, how much is the this thing? MSA? Yeah, here. No, at the
same point.
At the calcium ring.
Yeah.
Just
check the area.
Area, please.
Okay, it's okay.
5.2. Excellent. And how much was it earlier?
Go to the previous image.
अभी होगा, अभी balloon फैलाया हुआ है ना, अभी होगा.
So 1 minute 30 seconds are over. I think it's reasonable time. We can go up to 2. Patient is tolerating well. We can go up to 2. 1 minute 40 seconds. 1 minute 45. So this was again after that. Yeah, this was the point. Yeah, here, no, measure here. Okay, done. This was 3.8.
Yeah.
So we have gone from 3.8 to 5.2. 2 minutes, okay.
Deflate.
Go down.
Deflate, please. So we have. Okay.
So I think after the drug-eluting stand, this is the next revolution in interventional cardiology. When we are going away from the stands, definitely this is to be used by more operators. Right now, only few operators are confident in doing these kind of cases. So we have to see how well it is adopted by the other cardiologists.
So once we have this de novo study, the results, that will be, in fact, in this Euro PCR, there was a presentation on the interim outcomes, which was looking quite good. Check, please. That looks fine.
Good result. No major dissection in LAD.
Nothing.
Lesions have opened very well.
Yeah.
Maybe the distal part, if you want to do.
No, it's okay.
It's
I
okay.
think it's fine. There was
actually is also doing fine.
It is the straightening effect of the whole thing. There is no dissection at all. Now you see that there is nothing, no dissection. The lumen looks good. The side branches flowing well. Now the only question sometimes we may ask is that whether we should do a DEB to the diagonal.
Diagonal or not.
I mean,
it's a calcified diagonal and diffuse disease.
Let's go to the iliocranial. We can even do a DEB.
Yeah, we need 2.5, 20 will be required if you have to do it.
2.5, 20 or 15, whatever.
Yeah. 15 is also okay.
Oh, that's nice. Very nice.
I think flow is good and there is no dissection. It's divided into multiple branches and the actual area is very less.
Yeah.
We can leave it without a balloon
also. We
also.
can leave it without a DEB also. And we see that, can we give some nitro, please? And the patient is absolutely comfortable. Let's check the IFR now. Check the IFR. Get a 2.5 DEB. Why not? I mean, once we have done all the dilatation.
Okay. Diagonal 2.5.
15
will be fine.
15 is fine. Can we have the IFR, please? It's attached. No, it just came. Yeah, it's okay. It's fine. Absolutely perfect.
The flow is really good.
Absolutely nice and
Save frame. Save frame on last में.
Yeah. Okay. Fine. So let us now do this diagonal with the DEB.
DEB 2.5, 15.
Yeah. But after doing this,
We may have to do it LED again, so that will be an issue. Should we do it bifurcation kind of kissing with the same solution balloon with if let's be having some drug?
But not necessarily, because proximally we are not doing anything.
Okay.
Proximal part vessel is absolutely
We can
normal.
go beyond the
Yeah, just
bifurcation in
beyond
L
the
diagonal.
So this is a 2.5 into 15. Again, the same solution SLR, and okay. 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 Goes easily. Not much of a problem at all. Check, please. Very nice.
Go more.
Go more. Okay. Come to the other view, please. Epicranial. Ah. Okay. I think we are fine. Okay,
Now
go
it's
up.
okay.
1,
Go up.
2, 3, 4. 4, 5. That's good.
So in LED we have done IVL, so there was no.
So, it's fine.
Yeah.
I think it's quite good. So we'll keep it again here for about 1.5 minutes, and that should be all. So this is, we are now very confident that leaving these kind of proximal or mid LED lesions after absolutely good, treatment of the vessel with cutting balloon, with shock waves. So do a full treatment and then do a drug-eluting balloon. It works very well.
So Dr. Chandra's experience has, I think, crossed more than 100 cases now, and the patients are doing fine. It is increasing our confidence day by day that more patients are going home without a stent and they are not coming again for any kind of complications. So this gives a lot of confidence, and once you do it yourself, then only you develop these confidence.
No,
So you
many
can't. Yeah.
patients were actually, this all started because many patients were actually waiting for some kind of a urgent surgery.
Yeah.
So in these patients, we started doing this, and with that, everything became very predictable. And these results are very predictable. They are like so we call that that if you don't put a stent, there is no stent thrombosis.
Yeah. And for future also, if there is some lesion after 10 years, the vessels are still there for any kind of future
Vessel
treatment.
remains natural.
Yeah. So if you put too many stents, then nothing can be done. Recurrent restenosis, and it's very difficult to deal with it. Patients are coming every 6 months for a restenosis, and you are dilating them, and they're coming again. You can't do anything for them.
Okay.
Deflate.
Deflate.
1 minute 48 seconds. Deflate now.
Okay. Take this out. Oh, this looks
You can
good.
leave it. Done. LED, we have to just take a shoot
Not
and then decide.
necessarily. Take a shot.
Looks good.
I think everything looks fine.
Yeah, LED ostium is fine. There is no major dissection. Diagonal is flowing well.
We can
No
check
major
the
dissection.
final
IFR
IFR.
0.93. Now, after the diagonal dilatation, there is
We can do
some
some
change.
dilatation with
Yeah,
a
I
3
think
millimeter
with
balloon.
the same 3-meter IVL the balloon, there is still some drug in this, so possibly that will be used and it will give us good result. So this is how this behaves. So you can very well see what is happening to the vessel with just low pressure dilatation diagonal. You have seen that already FFR is changed. And now after this, we'll again check. Whatever we are seeing on fluoroscopy may not be accurate, but FFR values will never defy. we can rely on them.
And plus, we have done the IVUS also
Yeah.
to see whether the lumen was good or not, and it was quite nice. Sure. Here's the final inflation. Okay, go up. 1, 2, 3, 4, 5, 6. Okay. Connected. Right. Reflect. Okay. Yeah. Yeah. Okay, so the balloon is out, and I'm going to do a check. Wire has come back a little bit. I think I can.
You can leave it because if we go in a dissected,
Check.
wire can cause a problem.
Okay, let's take a shot. Final shot, hopefully, and that should be the end of the story. Check, please. Little check.
Yeah.
That looks nice. Store it. Store it, please. Yeah, that looks good.
Yeah.
Do a ariocaudal position. So both the arteries are doing very well. There is no major dissection. The lumen is opened up, and we will check in this view also. Okay. Remove that. Okay. That lies. That's nice. So there is a.
So diagonal is having some
diagonal is having
dissection,
some dissection,
but flow is really good. So this is the difference between a vessel treated with IVL versus a vessel treated with cutting balloon. And vessel with IVL, there is no major dissection, and flow is really good. No haziness in between, and in diagonal you can see some laziness. But I think flow is good, and we can leave it. If we put something to diagonal, then we have to put a stand in LED.
No.
And overall result will not be good.
So
it is same.
I think it is better to leave it as such because it is everything is okay. Patient's ECG is absolutely fine, and he has no pain, and his hemodynamics is okay.
Stable.
His angiographic picture looks absolutely fine. TIMI 3 flow. So we are done. So we can take this guiding catheter out, and
so I think this will be the future of intervention now, from balloon to stent to again moving to drug balloon and without stent. So possibly in near future, most of the angioplasty will be done like this. Still, we are stuck to our stents for so many cases, but possibly this is the future.
No, if there was a dissection in the LED and there was reduction of flow or the lumen was not good, then certainly we'll have to put a stent. But here it was very easily avoided, and what we could achieve was that this patient will not need long-term dual antiplatelet therapy. He is already a 70-year-old, very thin, fragile person. The second is that he will not have any incidence of stent thrombosis because there's no stent, and then of course this bifurcation remains clean. So that's, I think that will help.
This is the nice way to demonstrate new technologies, that using IVL, using IVUS, using imaging and physiology in a right way to give a good result to the patient.
Yeah. Okay. Thank you very much.
Thank you, Dr.
Thank you. Bye-bye. Okay.
The patient was nothing, Dr. Borgman.
Patient was?
Nothing.